to our university. So Dr. Carsten Schultz has held the chair of technology management at Kiel University since 2012. And his research interests include the measurement and enhancement of innovation management capabilities, and also the introduction of digital service innovations and the success factors of technology that transfer and innovation ecosystem. So I think that the purpose of this the talk is that because we know that we have lots of AI applications in recent years, but it's very difficult to implement an AI into our hospital system. Also, it's even more difficult that for example, the doctors and medical professionals that to accept the use of AI in their daily life. So it's a kind of a process that we need to overcome. So maybe Dr. Schultz, you can give us some inspiration about how can we just use the AI in our daily practice. So without further delay, let's welcome Dr. Schultz. Thank you.
So I need to use it because of the recording. Otherwise, I could also do it, but then it's. Should I do it without, or it's easier? So I do it. I do it with it. So maybe just to give you a little bit of background to whom I'm talking with. So actually, I have some responsibilities at Kiel University as the dean of our school, and also some responsibilities in our cross-faculty research areas. But maybe some of you, now it should work. Yeah. But it works a minute ago. No. Oh. Yeah, now it works. Okay. Maybe some of you may not know Kiel. Just by accident. Kiel is a university, actually the most northern German university, right at the Baltic Sea. So where it's cold, where we have a lot of sailing. This is our main campus of our university. This is the institute building. It's, as I said, very much up in the north. Kiel University is a very classical and an old university since 1665. Around we have 8 faculties, and I am the dean and part of the faculty of business, economics, and social sciences. But what we try to do in Kiel is to set up strong collaborations between the other faculties. This is also the reason I'm talking today about the healthcare medicine part, because I am part of this business economy and social sciences faculty, but together we work together also with the medical faculty in our research priority research area, ZEC it's called, where we focus on change and transformation processes. So we have at Kiel University, just only to give you a brief idea, we have the idea to really set up interdisciplinary research areas, and I am myself, we are part of this one, where we look at change and transformation processes beginning from the ancient times, so 10,000 years ago until today. So we work together with humanities, with historians, but we also in particular deal with the current changes in technologies and society and cultural change. And of course, as a classical basic research-oriented universities, we have a strong focus on natural scientists related, for instance, to marine sciences. We have the second largest university medical center in Germany. You may have heard of Charité in Berlin, the University Medical Center in Kiel and Lübeck, part of the Kiel University, is the second largest in Germany, looking very much at life sciences. Information research, for instance, is one of the big topics what we do. And we also have a big research area focusing on material sciences, in particular also focusing on medical applications. Just before I come to our topics, in our research area, we focus, as I said, on the change and transformation topics, and this is driven by different drivers. So starting with climate change, but it's also related to cultural change. If you think about what's happening right now with all these backlash activities related to political changes, for instance, in the United States with the Trump administration, what does it actually mean to our societies, to our organizations that are current topics which we are focusing on, and we do it from a very interdisciplinary perspective. I will drop it. This is our faculty, maybe some last words about our institutes, or our research center, you may also call it, on responsible innovation. It's a bit oddly stretched here. We set out to establish a research center, Kiel Institute for Responsible Innovation, where we look at organizational capabilities and individual capabilities when it comes to responsible innovation. So not doing innovation by itself or for its own purpose, but also reflecting on the impact on society, on ecology, but also on the long-term prospect of the economy. And what we want to do is not only talk about it, as we all know, all these greenwashing activities, and all we talk about in the healthcare system about patients. So we also try to implement innovations, transformations, which really take care of this society or needs, or in this case, the ecological needs. So what we do in our research center, or Kiel Institute of Innovations, is that we want to support individuals and organizations, societies, not only to do good, but to avoid harm. So how to actually reflect on negative consequences, for instance, of biomedical innovations, of artificial innovations. And so in our terms, responsible innovation refers to the question of how. So how to do it, how to manage it. So I'm very fast to get to our actual topics here. And the topic is therefore interesting because if we talk about innovation which tries to reflect on this non-intended consequences, the innovation itself, the transformation itself becomes more complex because we have to take care of different, sometimes even conflicting goals. So if you think about the healthcare system, we not only talk about patients' needs, but we also talk about economic needs, for instance. If you talk about responsible innovation, it's very much about the long-term prediction of future. So how can we actually deal with this uncertainty, and again, how can we deal with this conflicting norms and values, particular also when it comes to the field of digital medicine, which I will come to it in 1 minute. And this is the setup of our research center. So we focus on different capabilities coming from foresight, anticipation issues. So how to do it, how to analyze or to reflect on this consequences, how to include stakeholders, to include patients, for instance, within innovation processes, which new kinds of leadership styles are necessary to do so. So do we in the healthcare system still need to rely on the old hierarchies, on the narcissistic medical director idea, or do we need to have different styles and skills? And how can we set up an organization which is responsive, which is able to adapt to these different perspectives? Now I come to the topic. So this maybe reducing a little bit the speed. So what I or my research group is doing is that we focus on technology and innovation management. The management, so as I understood, you are medical students. Management is the discipline who tries to understand how can we change individuals, medical doctors, organizations in a certain direction. How can we actually manage, for instance, projects, but also entire organizations with regard to innovation. So which strategies do we need? Which cultures do we need? How can we set up innovation management system starting from the front end? So how can we understand ideas? How can we involve, for instance, what we are doing, medical doctors in ideation contests? Under which in which context does it actually happen? What is the motivation of medical doctors to do so? If you look today at hospitals, hospitals are actually organizations which are very much characterized by projects. So there are a lot of projects going on. We implement software, we implement new standard operation procedures, we implement new technologies. Hospitals at every grade are involved even in development projects together with industries. So how to manage this, how to also overlook it in terms of a portfolio. This is stuff what we are doing. Since 2001, I am very much involved in telemedicine. Telemedicine more as an umbrella topic, how to use digital technologies to implement personalized medicine, to treat patients based on the individual data, but based on the question what consequences does this have if we have data-driven personalized medicine. And very often these consequences are disruptive in nature, because what we as hospitals do is not the same as in the future. Stuff what we are doing, and we will focus on it in a minute in my main presentation, will be done in the future by outpatient facilities, because we have all the robots, we have all this artificial intelligence purposes. Just an example of one of our projects where we work together with hearing aid manufacturers. Hearing aids, as you may know, are nothing else than little computers, little sensor platforms in your ear. You have in-ear hearing aids, and in particular the big healthcare the big hearing aid providers are all on the way to think about which other medical sensors can we actually implement on the hearing aid. We can think about voice recognition, voice analysis, but we also can think about heart rate variability measurement within the ear. We can also think about movement detection. And then the question is again, if we have all this health data related to the personal life, how can we use it? What does it actually mean for the audiology business in the first step? But also how can we use it within other disciplines like cardiology? And what we also look at is the question, how does actually such an innovation ecosystem works, also beyond the research disciplines. So what we do, just as a last introductory word, is that we try to understand how the people from different disciplines, like from the ocean research discipline, work together with the medical scientists to develop and later implement, for instance, future early diagnosis tools for osteoporosis based on a measurement approach what the colleagues developed and used for the coral reefs monitoring. Because in both settings, the isotope household of calcium is changed. In osteoporosis, your bone fractures are changed over time, and that can be that is reflected in your calcium isotopes. This is the same as for coral reefs. And what the colleagues do is to look for such transfer possibilities from the ocean research, the marine research, to the medical environment. And we look at this question, how to manage it, because that is our job. So we look always at the question, how to manage it. So this is As an introduction, today I want to talk with you about the disruptive potential of artificial intelligence in healthcare, and I try to summarize some of our recent or current research projects, but I will also start with a little introduction, just as a purpose that everybody is starting with the same idea. I think everybody of you have heard about it. I also learned that you even may have some lectures on AI in medicine, but I will nevertheless start a little bit what we are talking about before getting into our current research about the consequences, but also the way how to implement it. So artificial intelligence is part of this digital world, digital innovation world, and I really like to start presentations in this field with this article from 1970. So it's in the New England Journal of Medicine, and the colleagues, one colleague, Mr. Schwartz, talked about computers. And if you read it, it's the same as what we are talking today if we talk about artificial intelligence. So we use this computer stuff as an intellectual, deductive instrument. It's a consultant that is built into the very structure of medical care system. So more or less the same what we are talking about artificial intelligence. So it augments or even replaces many of the traditional activities of the physicians. And that is an article, as I said, from 1970. So it's more than 55 years ago. And if you think about how much of those instruments, the tools, are actually implemented, it's, at least in Germany, and we discussed it in our meeting before, it's relatively little. And the question is, why is it the case that there may be a technological issue? Yes, of course, it is technological, what we are talking about. But in my experience over the last 25 years, it's not only a technological issue, it's very often not mainly a technological issue, it's a behavioral issue, which actually hampers the implementation of these new technologies, like in general computer or today with all artificial intelligence tools. So what we're talking about is, and you may all know it, that we currently and in the future even more we collect every kind of data which we have in our electronic patient records, from genetic data to lab data, patient records, even more related to the actual lifestyles, wearables, not even within the ear. So we have a lot of data, and what we of course do is with this data is to predict outcomes, to predict future behavior, future health statuses based on machine learning and deep learning, and as I said, basically as the idea to have a preventive, predictive, and personalized care. So this is, in a very nutshell, the main idea of all the stuff what we are doing related to machine learning, artificial intelligence in healthcare. So to use all the data, for instance, what we do a lot in chronic heart failures, to predict what is the future health status, what is the likelihood to get a decompensation of my heart issues. What is the likelihood that the patient will benefit from a specific treatment? And this is a predictive medicine, and based on the data, we can at least create some probabilities of future development. And we do it in a very different application fields. What you also will see in one of our projects, we use it, for instance, for risk assessment. So what we do at the medical center in Kiel and Lübeck is that is currently a project where every patient which is admission to the hospitals get based on the medical data, risk perception, for instance, of a respiratory insufficiency or other issues like sepsis. This is based on just a pattern recognition. So what is happening very likely with the patient with this kind of data. We use it, of course, for diagnosing whatever treatment for every condition in cancer, for instance. It's also sometimes related to robotic surgery. It's very much used in monitoring in community health applications, and of course there will be also perspective. We as patients use it ourselves as a vehicle to manage our healthcare processes ourselves. Just to give you some examples, my group is involved. I strongly work together with Stryker. It's as you may know, a big medical technology company in Germany, very much focusing on trauma surgery. And what we, for instance, do, this is a nice example, is of what Stryker tried to do, is to implement this device. It looks not really complex. It is a device based, again, on some machine learning tools where the surgeon gets a notification how to implement this nail for hip fracture. So how should the nail be implemented? It's also observing the medical process. It's also predicting the future outcomes based on the intra-surgery data, and is very much connected, of course, with the physical product. So, for instance, the Scammer nail for hip fracture. It costed Stryker, I would guess, $100 million, and is now stopped. It's not used and is not marketed anymore, not because it has no medical needs. It's because what you do with this system is to observe the surgeon's behavior. You're also actually taking away freedom to operate. Because what you do is to say to the surgeon, please do it in this way and not in a different other way. So you are not so flexible anymore to adjust your actual behavior to current medical needs. Even if, and this is the idea of all, in the broader sense, artificial intelligence tool, even that on average this treatment would be optimal, you may decide as a surgeon that this individual structure of the patient, a different position of our nail would be more beneficial. And the main reason this costly system actually failed is that you create data, you create transparency. Now it gets transparent if this treatment, the surgery fails. So because now the surgeon may be actually sued, for instance, in particular in the US system, but also in the European health system, because maybe he did not perform the surgery in a very good manner. And now it's all on record. It's all documented. And if you think about as a future surgeon, do you want to have it? Do you want to have a system which can observe and you as strictly as this tool actually does? Stryker is also doing medical robots. In this case, is for a knee implant. And this is actually, it's getting to be successful, but it lasted for several years. The market introduction was very much difficult. And what Stryker is actually proposing with this medical robot is that even I, as a non-medical doctor, can actually perform this replacement of the knee implant. Because everything is automated. It's more or less a system which, if you do not violates the system, it can't get wrong. And that will be the topic of my talk. What does it actually make with your identity as a doctor if you are not the master of the robot? So you do not use this tool, but the tool is telling you, you have to do the surgery in this particular way. You have to implant this knee implant in this particular way. And even this is a force feedback system. You can try it. It's actually not able not to do as the robot tells you. And so it's more theater. What is getting played, what the role of the doctor actually is in the system. This one I already said. I skipped this. This is the example I will use in a second in our project. Just to explain it a bit more in details, I think I'm absolutely sure that you see very similar tools here in Taiwan. So in this case, based on 12 years data, based on a broad consent, we have all this inpatient clinical data. And what patient get is a risk score, like in this case in German, is a risk to develop an respiratory insufficiency, so that you have a particular lung issue. And in the systems, what you do is you try to deconstruct the probabilities to different information aspects, and this is as an actual screenshot, a part of the screenshot. You also see it in a cockpit version, so you can manage the patient. But again, the question is, and that will be the topic again. Now you get this risk score, 83% of developing this lung issue. And what you also see is the system does not stop with it. You also will tell the medical doctors, okay, this patient with this particular high risk needs to have this monitoring activities, these procedures. So you really tell the medical doctors what to do. It's good for the patient, no question. It's also at least validated in the clinical setting. But again, the question is, what does it make with us as medical doctors? How does our role change, and how does it actually influence our identities as a medical doctor? And we could go on and on with all the examples, because we see a lot of applications of AI where studies shows that these tools are getting better and better, in particular when it comes to radiologist tasks, but also a lot of other tasks. If you look at this slide, this is from a very good annual report that comes out every year, where they try to bring all AI studies together. And what you see here over time is related to this technical part, and which parts the systems get even better than the human baseline. So the 100% is all the different application fields as a human baseline. So we have in particular this operational task, like a evaluation of an X-ray or a CT, where so image classification, where the tools are better, much better than the average medical doctor. And then the question is again, what does it mean to us? Because if you see it from a more abstract level, all the tools do the same. So they has this technological support, knowledge transfer from experts to non-experts. As I said, even guys like me may be able to implant a new knee, or maybe we have not to go as far as this. But so activities which used to be part of the University Medical Center will be now part of a remote hospital, now part of the outpatient physicians. It's it's partly all, these are tools which actually support patients to do their medical services themselves. In particular, when it comes to diagnosis, how does this influence the roles, the identities of our medical doctors, and even further, some of these tasks get so much automated that no human being will be involved. And this will be, this is the perspective in this bigger research project we have, and we focus in this research project on a construct or an aspect which is called professional identity. It's a theory more coming from the social sciences, and what we believe to be a maybe one step back before I come to this, to be relevant is that we believe that these technologies will change the role we or our medical doctors has in the future. And professional identities are these identities which are constructed to define ourselves in comparison to somebody else. So we as an in-group, we as medical doctors are different because of certain activities, certain beliefs than the non-doctors. I'm working quite a lot together with medical doctors, also in training. And what I always say is, actually overstating, but so there are two, from a healthcare professional side, medical doctors, there are two kinds of human beings, medical doctors and the rest. And this is particularly the case because medical doctors developed a very strong professional identity, because I identify myself with the medical profession. So I am the medical doctors in cardiology. If you ask, you all know, maybe your parents, whatever, relatives, at least in Germany it's the case. So if I would be on a party and in Germany you stay in the kitchen during the party, it's obviously the case, and you chat and then you talk about, okay, what you are doing. If you would be an engineer, the people would say, oh, I work for Siemens or I work for BMW. A medical doctor always says to you, I'm absolutely certain, I am a cardiologist. I am a surgeon. Because they identify themselves with their profession much stronger than every other profession. And now, and this is the story here, now we have all these technologies, which is really influencing the roles, my self-beliefs as a medical doctor. And what we did is, in a bigger research project, we tried to set out to understand it. Firstly, you don't have to read it. Firstly, in the context of data-based or AI-based clinical decision support systems. Because, as I said in the beginning, it's a process what we see. AI is not new by itself, it's a process, and part of it is also true in all these clinical decision support systems we have at place. In this first step, in a review, we analyzed in some 131 implementation projects where we went through the data and analyzed, okay, how did the physicians actually react on it? How do they feel? And this is based on, just to give you a little bit of background, that also theory-wise, the sustainable, so long-term implementation of every technology, of every process, is based on certain aspects. So the theory of planned behavior, so is a very broad theory, and in every context you can think of, basically said that, of course, if we want to implement it, we have to develop a positive attitude to it. And this positive attitude is actually related to to three very important aspects. Of course, the technology or the process, in our case, the AI technology, has to be better than the status quo. So, so we have to see the relevance of the need to change. So, why should we actually use this AI-based clinical decision support system? What we also will see is this attitude is also related to my own perceived behavior control. I only use the technology and I will adopt this behavior if I believe to be in the driver's seat anymore still. So I want to have a behavior control. And this is also related to my own knowledge. If we would talk here about patients, it would be about data literacy, health literacy issues, but it's also the support I get. And what the focus of this talk is, it relates very much to the compliance with our norms and social values. So I only use these technologies if I believe this fits really with the social norms and values is what medical services should be and a medical profession should be in the future. And the professional identity, just to introduce it a little bit more, is nicely reflected in this quote here from a very basic publication here from 2006. It's also reflected in this view on medical doctor to be an artist. So we as medical doctors may believe it as an art to do medical practices. Nicely reflects the identity, and also already said that it defines the gap between my group, my in-group, the medical doctors, and the rest of the world. What we saw in this first review, only to give you some insights, is 131 implementation projects. So we summarized quotes. So we saw in this, even not so much AI-based project, that is that a medical doctor said, okay, I want to be still in the driving seat. It's under determining my role as a provider. I'm feeling subordinated, so dominated by those technologies. I will skip this one, but only maybe as a reference for colleagues who may further interested in it. Then we developed a certain kind of theory. I will send the slides later on. So that based on it, so we try to understand what are the driving forces because of this perceived threat, or even sometimes an enhancement of our identity. And we see it, of course, on the individual level. It depends again on literacy aspects, on general attitudes towards innovation. It depends on the organizational context. So hospitals react differently. So because they have different management capabilities when it comes to change and innovation, also different cultures, and it depends, of course, on the setup, on the technology itself. What I want now, in the last part of this talk, want to share with you as two studies where we focus on two actual implementation projects, because what we saw in this review, and also I think you could agree that if we really have a technology like an AI which may be perceived as a threat to my professional identity, this is of course not good for the implementation of our technologies. And what we look at are the threats to individual expertise, autonomy, professional identities in a broader sense. But you also look at aspects like, do we trust into the system, and under which conditions do we trust more into the system than others. As I said before, the first topic would be this one. So this clinical decision support system, as I said, you may have similar technologies in process here. Again, it's a risk prediction tool. Actually, just as a side remark, this is a collaboration between our University Medical Center, Tiblu. Tiblu is a startup in the AI field where Tiblu was provided with this health records. So 12 years of health records, and Tiblu was able to use it to train their algorithms and is now implementing it in the actual medical context. So what we did, and this is then our part, is that within this research or this development project, we discussed with them. Okay, there are three different possibilities what we could do. So as I said, maybe one step back. The first alternative would be we just present the doctors with this 83% of risk. Or the other alternative would be to present them with this, what we may call explainable AI, so some deconstruction of these probabilities. So what are the data which led to it? Like just to say, like the diagnosis, the early diagnosis, the age, some lab data, etc. So that is the first question we have. So there are two possibilities: only the risk score or this explainable AI. The second alternative we have in this process is: should we give the doctors even more than 83% of risk? Should we provide them with the actual clinical workflow? You have to do for this patient with this particular risk pattern this and this, in terms of monitoring the patients, in terms of management, this lung issue and other applications, second application for sepsis. There are very strong procedures in place for sepsis management. So it's an open question. So should we do it in one way, so with 83% alone, or with a strong integration in the clinical workflow? Should we provide them with the standard operation procedures? And the last, the third dimension is focusing on the accountability. So very simply spoken in the system, should I require a signature, a digital signature within the system? So you as a medical doctor has to sign, okay, I saw this 83% with this workflow or not. Because this will create a certain accountability. So what we, just to present you some descriptive empirical data here in a research seminar. So what we have is we have these three dimensions. Every dimension has two options. So we have in some 8 different scenarios where we combine these three dimensions, and within a test with, in this case, not very experienced medical students in the 5th and 6th years. So within the medical training, so we developed some scenarios or some mock-ups of the tool, and then we tested the reaction towards the tool. And what we saw is that the tool is perceived differently based on these 3 dimensions. Just to give you an example, sorry for this, supposed to be gray, just to focus on scenario 8. Scenario 8 is this one, which is mostly trusted. So it's a scenario where we have an explainable AI. So we have this additional information, which is very deeply integrated in the workflow. So we have this follow-up procedures implemented into the software, and we also have this individual accountability. So the doctors needed to sign. Then the doctors trusted this system more. And interestingly, if we look at the professional identity, the results are different. Are the same 8 scenarios, so it's the same 8 mock-ups. And what we see is that the lowest, this one, big one. The scenario with the lowest threat to professional identity, which is the best for implementation, is scenario 3. And scenario 3 is the one which is non-explained, which is still in this case deeply integrated, but has no individual signature. Just to sum up this regression, because we also did it differently in some regressions, whatever. So what we really see is that the design of the tool, the process of the tool, is influencing in the trust, but then also the threat of professional identity. And what we also do now, while this is really implemented, we will also look at the actual implementation. That is an ongoing process. So what we see, if we understand it, for instance, explainable AI is positive for trust, but also creates a threat to professional identity, because now we understand why this tool can take over parts of our activity. And for instance, we see, so if doctors need to sign, take accountability, that increases the threat. And if we as hospitals or as software providers want to deal with it, we can react to it. The second example, then I think I have to speed up a little bit, is focusing on the question, what now? How, if we have a tool, how can we implement it? How can we communicate with this tool? And this tool is, I skip this, is focusing on this audiology hearing loss field. So KIND is one of the bigger healthcare providers for hearing loss, active, I think, in six or seven European countries, German-based. I don't know how it is here in Taiwan, but a classical or current today's hearing aid service is basically a person-to-person service. So you or your grandparents or whatever go to a medical office, and you get all the counseling, all the support, all the fitting of the hearing aid. Now, bigger parts of it get replaced by technology. And it's not only the supporting activities which are stated here, but it's also that bigger parts of the core medical activities, so the fitting of the hearing aid, the technical characteristics, are taking over by the device or by remote service centers. So you have over-the-counter hearing aids, which is partly driven by cost issues, like in the Veterans Affairs in the US, but it's also, of course, driven by the aspect that you can fit your hearing aid to your needs within your own environment and not in this artificial hearing office scenario. It's even further that we also did it some years ago in another study, analysis, but we also see it, for instance, if you buy an AirPod. An AirPod is currently marketed as a device, actually as an all-in-one hearing health experience. So, because at the end, the AirPod, every current speaker, in this case, is having the same technologies as a hearing aid. It's completely the same technology. And the question is then, how do we as a service provider can actually implement such services which are good, again, for the patient, and also good in terms of efficiency, because we have more and more old people with hearing loss. So we did it in with regard to this research projects, which I already mentioned. We will only focus on first on the right-hand side. What we did here, and that is what we do a lot. So we set up experimental designs, like in medical testing and treatment testing. In this case, we work together with a bigger hearing audiology service provider. You can guess who. And here, so we introduce this new service, this AI-based remote actual fitting service to the audiologists, so real healthcare professionals, not students, 143, and we communicated it in a different way. We call it here framing. So we communicated it in a different way. We communicated it in a first options from an employee perspective. So you as an audiologist, you will profit in terms of you have more time, more efficient, better planning of your service process, or the same service, but other audiologists get it communicated from a customer or patient perspective. So your patient will benefit in a certain way, or etc. And we do it in a framing perspective as a promotion, promoting the future benefits, the potentials of the technologies, or we also combine it with prevention framing, basically focusing on the current sacrifices. Why do patients lack the good service? So again, we in this case we have 4 different setups. It's not a software mock-up. It's a different communication instrument which we used. And again, you see the pattern. We looked at in a descriptive way at differences. For instance, in this case, because they are actual audiologists, and they were asked, okay, do you want to use this remote fitting within your actual health services? And what we see is that again, the same service, the same technology is perceived differently based on our experimental setting. And what we see is if we want to increase the intention to adopt, because that is the thing from a normative side we may want to have because of the patient's need. We have, in first view, we have two options. We can focus on the customer, the patients, but here we should focus in our communication on the current sacrifices, so what we try to prevent, so the patient lacks good service today, or we have other possibilities. We can focus on the benefits for the employee, but there we really need to focus on the gains. So you as a frontline employee, as an audiologist, you have more time, you have less stress, etc. And interestingly, and that is the last part, it differs a lot between 2 groups of employees. So before these experiments, we also ran the survey, and there we ask the employees in a survey, in a standardized questionnaire, how service-oriented you are. So very briefly, how much do you care about the customer, the patient? And it's just a median split, so the high and low service orientation. And the only thing what is necessary to remember is that both groups of employees differ extremely in their response to our communication scenarios. So the pattern which we just saw is basically only the case for the people with the high service orientations. So other service providers who do not care so much about the customer, it may be straightforward. They should only be targeted with an employee-focused story, because they do not care. So that is just the idea. If we want to implement it, we not only need to reflect on the technology, what is the process, we do not only need to reflect on the preferences of the patients, but we also need to reflect about the preferences of the actual medical service providers, because not only patients differ, but also health professionals differs a lot in their attitudes and orientations. To sum up, what we look at, and that is the overall topic of our research, not only this one, so also other research, is that we look at the consequences of technological innovations on organizations. And what we look at is in particular on discontinuous innovation. So innovations which are not just an incremental improvement of what is going on. So like this AI is certainly not only incremental, it's something radical, it's something discontinuous. And we may even see it as a so-called deprofessionalizing innovation. So that is changing the professions. It's questioning the fundamental beliefs of what we are doing, because all this technologies like AI, like robotic, they have maybe two particular aspects. They substitute what we are doing, and they lead to a loss of power of current healthcare providers. Just to repeat myself, if you remember what I said, all this AI and robotic tools partly reallocate health services from an expert level to a non-expert level. And if you do so, these actors on the expert level, of course, they will face a loss of power. A loss of power in the health systems relates to disruptions of the business models, because you are not as much as influential on the revenue stream. You can, you as a health profession or as a hospital organization, you will lack patients. Patients comes with revenues, and not only that you, it's also true in the audiologists, is that you will face a reduced number of patients, because this will be good, because we have a high burden patient load. But what you will lack, or what we will see, is that the easy patients, so the patients which are very close to the actual standards, they get automated. They get be transferred to non-expert levels. So so maybe that are 50% of the patients in audiologists. We also saw the same pattern for chronic heart failures. So the easy patients get reallocated to other facilities, even to nursing services. What remains are the complex cases. The complex cases need time, they need consideration, and at least in Germany, but if I understood it correctly, also in Taiwan, the revenues in the healthcare system are based on average calculations of patients. So on average, you get for a certain disease, for a certain treatment, a certain revenue. What happens if the easy part of the patient get replaced and only the complicated ones, you have a negative profit. So you will lose money on average for every patient. And even if we are in a public healthcare system like in UK, it's still the same, because still you need to have resources to provide to hospital services, and if you lack the easy one, you cannot afford all the experts, all the medical technologies anymore, which you need for a high standard treatment. And if we believe that is only true for hearing aids, of course it's true for every technology. It's the same story in every industry. It's like for mobile phones. It will be the same story for the automotive industry in Germany. If we believe that can't happen to us, I think then this is very dangerous, because at the end it will also will be related to us as hospitals, or you can also replace with medical professions. So who will remember, who does remember Nokia cell phones? Nobody, at least of the younger ones. Who will remember maybe this hearing aid studios? Maybe again is overstated, but who will remember certain service providers if you only prospect what is going on in terms of AI and robotics? That is interesting, and you as a young guys, you have to work in this environment. But maybe just to be sure, I'm not saying that we don't need medical doctors. And we don't, and of course we also need hospitals. We also need outpatient facilities, but the role in the system, the competences that will change heavily. And at the end, particularly if you are in medical training now, you will.
Inspirative talk. I think it's a wonderful discussion. Thank you so much.